So I'm here to talk about sustainability and global mental health programming. Bev has also asked me to speak about funding. So as I do my talk, I just want you to think about the type of strategy I'm talking about and what that would mean if you were looking for funding in the countries where you work. So first, this all stems out of my work experience, not through SO, but through the work I did the last 2 years. It was a Dutch NGO, and my main mandate was to integrate mental health into primary care in 2 countries. So I want to describe a little bit more in detail the approach and why it was deemed sustainable, and then the challenges for funding. Okay, so here's what I was doing. I was working in Afghanistan and Burundi, 2 very different contexts, but both post-conflict contexts. And why integrate mental health into primary care? I would ask you if we had more time, but instead of brainstorming, here's a list of reasons why. And this is from the WHO, but also it sort of makes sense. So if you're trying to integrate mental health into a healthcare system, why not primary care? Because primary care reaches a maximum number of people in the population. It's a way to deal with the issue of stigma. It increases access, of course. It's affordable, cost-effective. It's shown to be linked to good outcomes. But is it feasible? And that's what our test, our pilot test, was for. Okay, so this actually is really important because in addition to the approach of integrating mental health into primary care, how do you do it? So I don't know is anyone familiar with this? It's the WHO Health System Strengthening Framework. Raise your hand if you are. Okay, Gary, thanks, Gary. Okay, so not so many, but I think it's something worth putting on your radar because this framework is actually how we approached our work in mental health in these settings. So if you can see here on the left, there's 6 system building blocks. And when you think about mental health overlaid on a healthcare system, this is what you want to think about. Service delivery is the top one. Healthcare workforce is the next one. Information, technology, medical products, vaccines, and technologies there as well, but that's health information technology, financing, and leadership and governance. So this is a very easy model by which you can think about, well, is the work I'm doing, does it address all of these 6 pillars, or does it have to? So for example, some of you are familiar with SO, the NGO that I'm working at. It's a social media site for global mental health practitioners. Where does SO fall in these 6 blocks? Those of you who are familiar with us. If we're a community of global mental health practitioners, which pillar does this address? Which one? Information is one, exactly. What else? So we don't do service delivery, but yes, indirectly, absolutely. Health workforce, yeah, you were at my launch, so you know. But those are the 2 main things. Only that, yeah, only that. No, of course. Thank you, Milton. But but the work I did at this NGO really spanned all 6 of these building blocks. Now you can see there's overall goals on the right. I'm not going to go into that for the sake of time, but if you're interested, please look at the WHO website or ask me for more information. Okay, so key concepts in addressing integration into the healthcare system. First, I've already mentioned strengthening mental health care. Second, instituting a pilot program. So you can't just start integrating without testing in one small area. So we did a pilot program, which I'll show a little bit later, and the idea is once you test the pilot program, you can scale up, and then there's task shifting and task sharing concepts that can take place, okay, etc. And then I'll go to the last 2. So even though this was a primary care project, still this system has to be linked to secondary and tertiary systems of care. So, for example, in Burundi, there was 1 mental health facility in the central capital. That was it. That was the capacity in country, and a few people who knew about mental health. And so our pilot program had to be linked to the central mental health hospital in the capital. I mean, and it depends on the context how you would set the program up. And then, of course, the final one, which is critical, is linkages to community structures. This could be traditional healers, other community-based programs. It really depends, again, on the context. Could be community health workers and training them as well to increase uptake into the system. Okay, so why a pilot project? Well, I don't know about you, but where I've worked, there is no data on mental health at all. And in fact, the ministry doesn't even understand the importance of mental health where I worked. So a lot of it was justifying why are we doing the work that we're doing. Of course, when you have a WHO representative right beside you, it really helps in terms of lobbying, but that's often not the case. So one of the things to think about, and this is the vicious cycle, in these settings where I worked, and probably many of you work, there's a low priority of mental health. So that often leads to a lack of mental health, which often then again leads to insufficient routine data collected on mental health, which then leads to lack of mental health data, et cetera, and it's just a vicious cycle. So we're trying to break this by doing a pilot project to show this is the data in your country to the Ministry of Health when we're lobbying. Okay, and briefly, we're using mhGAP. How many of you know what mhGAP is? Very good. Okay, so just briefly, mhGAP stands for mental health gap. So gap is the gap in demand and actual treatment available. So it's an approach to address issues of the mental health gap in resource-poor settings. And if you're interested, please go look again on the WHO website. It's very interesting, but we don't have enough time to go into it. We used mhGAP. We picked a small area where it was feasible to develop a pilot project. We piloted the program, and the whole point is to evaluate and monitor it so that there's evidence to the Ministry of Health so that you can scale up. So that's the general model. Okay, activities of the pilot program. This is not simply just working in that service delivery block. There's so much that goes into the approach that we took at this NGO. Even before this, we had done a lot of ethnographic, anthropological, qualitative research in that area. So we knew a lot about local idioms of distress, culture, mental health in that area. So that was already part of our knowledge base. But mental health activities, the first thing we did was convene, thank you, stakeholder meeting. And what is that? Stakeholders could be WHO, ministry officials, other NGOs, community-based organizations, to get buy-in, to get everyone on board. That was the beginning, followed by a mental health needs assessment, and you can see there's a series, there's a series of, okay, my alarm went off. There's a series of steps, and I can talk to you about this more if you're interested in the technical content of the pilot program, but I'm not gonna go into this right now. But I just want to stress, for sustainability, key point, you need political will and political commitment. It's a process. It takes a lot of time. It's interdisciplinary, multi-sectorial, and most of what I was doing was lobbying at the ministry. Lobbying. And then implementation must occur at the national level before the local district level. Okay, last slide. So what does this mean in terms of funding? I want you to think about it, because I was working at a central office where we were getting funding from the EU, the European Union, and then we were giving our money to our local office there. But what was happening was that more and more the money is going directly to the local NGOs or local entities in the low and middle income countries, not necessarily to the central offices where a lot of the technical expertise is. For example, in Burundi, there just wasn't so much capacity. Capacity was at the central office. So you can see that's already becoming an issue of funding if funding is going locally where there's no capacity and not centrally where there is capacity. So that's one issue. I think another issue that I saw is that oftentimes donors who maybe weren't knowledgeable on mental health wanted to fund vertical programs in mental health, isolated programs not tacked at the level of the ministry and government. And it depends on the donor, but we were trying to find, it was harder to find people that were willing to just pay to strengthen the existing system, even though we felt that was the way forward. There's many other issues, but I want you to think about that as we go through this panel. So thank you.